Let me introduce our panelists here to you. Joining us today from the Government of India, Manoj Jalani, the Joint Secretary at the Ministry of Family Welfare. Also with us on my right, Alok Kumar, Advisor Health and Nutrition at the Niti Aayog. For those of you who are not familiar with the new Niti Aayog, it's what the erstwhile Planning Commission used to be. Also with me on my right, K. Sujata Rao, former Secretary of Health, the Government of India. On my left, Dr. Winnie Yip, Professor of Health Policy and Economics at the Blatnick School at the University of Oxford. And right next to me, Dr. Abhijit Banerjee at the Ford Foundation, the Professor of Economics at MIT. So appreciate the panel joining us here. The brief to me was to be able to sort of condense what has happened over the course of the day, to take forward some of the conversations that have happened during the course of the day, to identify the specific pain points that continue to need policy intervention, both from what the private sector can do as well as what the public sector can do. And also imagine a re-architecture, so to speak, given the fact that we've now seen the 14th Finance Commission make its recommendations, which have been accepted by the government, which envisage a greater devolution at the level of state governments. So what needs to be done to ensure judicious mix of what the center can do and what the state governments can individually do? Where are we as far as healthcare reforms are concerned? Where are we when it comes to our aspiration of universal health coverage? What can actually happen as far as healthcare financing is concerned? And can we really expect, truly expect more government spending on healthcare? Let me get started with that point first. It's a little bit of deja vu because just on Thursday, I was at a similar conference where we were talking about financing. And I was with the Minister of State for Finance, Jayant Sinha, and I asked him, I said, you know, we've all heard these numbers year after year on how much India spends on healthcare. Can the government spend more? Can the government allocate more towards healthcare expenditure? And his answer, I have to say, was fairly candid and fairly straightforward. He said, we have a fiscal consolidation roadmap that we need to stick to. We have fiscal compulsions that we need to adhere to. And at this point in time, I think we need to look at innovative, out-of-the-box ideas on where we're going to be able to get the money from. So it seems fairly certain that it's unlikely to be a significant jump that we can expect as far as healthcare is concerned. Will that mean another cess? And God forbid we have another cess coming in. We've already got 27 to deal with, because that certainly is not an out-of-the-box idea. But as far as expenditure and the government spending is concerned, there certainly seems to be, at this point in time, less capacity on the part of the central government, at least, to spend more. What happens in the light of the 14th Finance Commission and its devolution formula? It does give access to funds from the central government to the state governments. The centrally sponsored schemes will be pruned down. About 8 at this point in time are being cut already, but eventually the government hopes that more centrally sponsored schemes will be pruned down or rationalized, and I know that that is something that the Niti Aayog is working on. So in that context, let's get started. And Mr. Jalani, let me ask you about what we can expect really as far as government spending on healthcare is concerned and the out-of-the-box ideas when it comes to financing as part of the national health policy.
I think today's deliberations have largely centered around more money for health and more health for money. I mean, that's the two themes under which everything can be brought under. Now, regarding this more money for health, let me first come to this 30 to 42% business. You know, when we look at this year's, say, health allocation, B2B, there was a decline. You know, last year we had a budgetary allocation at the B level of 22,000, and then it came down to 18,295 crores. Say, I'm just talking about the National Health Mission part. And now, but then, of course, towards the RE stage, that had come to about 18,000 crores, 18,100 crores in the RE stage last year. Compared to B2B, suppose you had 22,000 crores, we had correspondingly state share 75-25 would have come another 7,000 odd crores, 29-30,000 crore. Now what we have is 18,000 crore as the 60%, now the 12,000 crore comes from the states because of the revised sharing pattern. So to that extent, the social sector is getting protected, so to say, in the terms of at least this one key program of NHM. But now, whether the states indeed are going to put in more money or not is still a big if there. The general sense that we have during the currency of the year is it's not going to happen easily. And even this 40%, which is more like to get the 60%, state should be ready to pay that 40%. Even there, you may have challenges. While I
And
do,
sorry to interrupt you, but that's largely on account of the fact that state balance sheets are also stretched. I mean, the center has its own problem, but, state balance sheets are also stretched, if not more, actually.
yeah, I mean, I'm sure state finance secretaries would be in best position to answer that. But my own sense of having worked in the state governments and as well as the central government is that you are able to show much clear, tangible progress in infrastructure kind of sectors. So building roads or irrigation, dams or power, this thing, you say that pani, bijli, sadak, humne sab theek kar diya. In cases of social sectors, things take time to show results, and we don't really have very good, I mean, like if you were to track, I'm just saying, catastrophic healthcare expenditures state-wise, and then keep on showing ranking of the states as to how each of the states is performing in relation to catastrophic healthcare spending or out-of-pocket spending, and then how things are evolving. Maybe we could have states glued to putting in some resources for health, but as of now,
That's not the sense you
that's
get.
not a priority we have. As regards, I mean, the other issue is in terms of in terms of total health expenditure, my broad sense is for a country, in our context, it has to be largely tax-based financing. You have a very small organized sector, so really, in terms of social health insurance coming from the payrolls kind of a thing is not going to happen, and we really don't have. We'll have to think of very innovative ways of getting a much larger population who is as of now incurring OOPs to come together, and voluntary payments also don't work so easily in terms of insurance payments, but we will have to think of it. But for a very large sizable population, we'll have to think of, even for the insurance part, particularly for the tertiary sector where we have inadequacies in the public health system, we will have to go in for tax-based financing to at least pay for the premiums for the poor. And primary care, my own broad sense in terms of how it should roll out is that primary care largely has to be through public health systems. Secondary health care also should be largely through public health systems with complementation to fill in the gaps from the private sector. But at the same time, we need to work in terms of ensuring ways and mechanisms through building on information systems to be able to design our payment mechanisms in a way to ensure higher value for money.
So if I could ask you a straightforward question, sir, the national health policy is based on the principles of providing equity, universality, accountability, and affordability. In the light of the constraints that you have as far as financing is concerned, are you going to be able to deliver on all of those?
You see, I mean, that's the aspiration for everyone.
No, I mean, let's not talk about aspiration. I think we've talked about aspiration for too long. I'm asking a straightforward question because the policy itself...
It's not going to happen overnight. It's going to take decades. I mean, that's even our own plan document says that it's not going to happen in one plan period. It's going to need 2 to 3 plan periods to really achieve that kind of coverage and reductions in, achieving the UHC of the kind which countries like Thailand or Turkey have achieved. Yeah.
Okay, so that's a pretty candid admission there. Let me come to you, sir, because at the Niti Aayog, this is something that you're working on. And I started by asking about this business of the Prime Minister saying that we must work towards a model of cooperative federalism, and that essentially seems to be what is driving policy making, at least as far as, or thought making at the Niti Aayog. Now that the 14th Finance Commission has come up with its devolution formula, which has been accepted by the government, and again, going with the Prime Minister's theme that we don't want to design policy because one size does not fit all, what is this going to mean finally as far as reforms are concerned, specifically when it comes to healthcare?
In fact, I was not able to join you today in the morning because we were working precisely on this issue. So the point is that if you look at the total devolutions which are going to the state compared with the previous year, there is a net increase of about 10%,
Yeah.
which in any case is the normal way it would have been done. So what is being done with this additional 10% is that it is giving states a little bit more leverage as to where they want to put the
spend,
money.
yeah.
And the idea there is that for far too long have we, in the government of India, decided or thought that we are the all-knowing people who will be directing the states that you should put your money here, there, so on and so forth. And how we have been able to achieve it is simply that, remember, health is a state subject. We have only family wear, and that too is a concurrent subject. So we have been able to force the state governments to spend by using our spending power. So we come out with a scheme that if you do these schemes, if you put 25 rupees, I will contribute 75 rupees. And any state would like to leverage that kind of a finance. So what we are doing now is giving a lot of freedom to the states, even within the scheme. How those components are to be used by the states will be decided by the states and not by the ministries. So I think with these two changes, we would like to see much more actions at the state suited to the state-specific needs rather than being...
But if I could ask you, in the process of consultation, have you looked at the global experience where people have moved towards or away from centralization to actually giving the power to states or provinces to decide what their healthcare policy should look like, what healthcare spending should look like? Have you looked at global examples? Because while there may be positives, there are also examples that do show up the perils of too much decentralization in that sense.
Yes, okay. Too much decentralization is okay, but you please look at the basic document, basic philosophy which governs this country, and that is the Constitution. If the Constitution felt at that point in time, and it continues to be felt that it is a state subject, why should we start dictating or deciding policy here? Number one. Number two, Indian states, if you look at the across parameters, they are at different levels of economic development. They are at different level. For instance, if you look at health sector in specificity, they are different level of provider mix. They have different, state cultures. Some states have very good public health system. Some states do not. But we try to kind of make a uniform kind of a solution for all these states, which we feel should not be the case, and let the state governments decide. We will be there to support them.
But if I could ask you this, and again, because you brought up the issue that, like land, education, health is also on the concurrent subject. If we have a central...
No, health is actually a state
subject. But if we actually have a central law which is the sort of floor as far as things like land acquisition is concerned, which again is a politically sensitive issue. And you say that this must be the floor as far as rehabilitation or compensation is concerned, which then incentivizes the state to at least follow that, or at least not actually go below that. Would that perhaps not be the way that we should lean towards, especially in a country like ours?
I think that is exactly what our role should be. And I think that is what we need to work at. What are the basic minimum standards which we would like any Indian citizen to have? And to that extent, what kind of resources are required for that, and what kind of organization will be there? But please understand, we can only present it in a suggestive framework, not in a directive framework or a prescriptive framework.
Said you missed the proceedings in the morning because you were deliberating on this very issue. What is the outcome of the meeting that you had today, sir, if I could ask you that?
So the final outcome is yet to come, but
give us a broad idea.
I will give you a sense. So 10 chief ministers have given a consensus report on how these centrally sponsored schemes, one of which is National Health Mission, and there are schemes in other sectors as well, how it is going to be restructured, and in what kind of flexibility we want to provide to the states, what kind of transparent formulas we evolve for devolution of money under those schemes, dividing between the states, and what are the responsibilities we are going to look at, and what kind of accountability mechanisms. I am happy to state that most of these central government ministries, though there were a little bit of discussions, but most of them came around to the view that we should, by and large, accept whatever the chief minister has recommended. In toto, we go to the cabinet next. Let us hope for
So what is the broad timeline that we're looking at?
I think by the end of this year, so 31st, my deadline is 25th December, then it is up to the cabinet for the cabinet to decide when. I can't set a deadline for that.
Sujata Rao, you're listening to what we've just heard here on the part of the Niti Aayog, and it's something that is going to be taken up by the cabinet. What worries you about this re-architecture, so to speak, and what would be the sort of checks and balances that you would like to see in place?
You know, what worries me is that we are decentralizing to the states, which is very, very good. It's in the right direction constitutionally. As Dr. Rao said, it's the right thing for the 14th Finance Commission should have, has done. But I do worry that we don't have a shared value. It is not possible for the central government to say, health is a state subject, so do what you want. No, it's not possible. I don't think it's agreeable. Because no citizen of India can be penalized because of the place of birth. Bihar has 2.5% of the people have access to tap water. It's unacceptable. You cannot have a state where 80% people don't have access to a toilet. These are basic fundamentals. Now, there are historical reasons why why there's such wide disparities. So I believe that the first step in devolution and cooperative federalism is that the states and the center have to have shared values where there's certain minimum, basic entitlements that every citizen must get that needs to be costed, and the center has to also provide fiscal help to the states. Because large, as you know, Shireen, many of the northern states don't have the fiscal capacity. So center cannot just simply say, sorry, it's your business. And secondly, in the concurrent list, infectious disease is a part of the central responsibility. It's not possible to say health is a state subject, so tomorrow Mr. Chandrababu Naidu will say, I don't want to do any more immunization, I want to build hospitals. That choice cannot be given. I'm sorry, it's not possible, because Tamil Nadu, and he cannot threaten another person's health care because there is, borders don't respect infectious diseases. So I think there is a need to very urgently, which has not been done in all these 70 years, to say what are basic minimum public goods that have to be made available for every citizen. The center and the state have to then do a very critical fiscal analysis and see how the equalization funds can be created at the central government to meet the gap in those states. The states have to be made to do much more taxation, raise their resources, and stop depending only on the center. I mean, local bodies, have taxation powers.
Right.
Why are they not doing? Why is agriculture not being taxed? So the states don't also want to accept their own responsibilities. So I think unless and until there's a shared expectation and shared value systems, just merely passing off the buck to the states is not at all a good development, and I'm worried.
Mr. Kumar, you want to come in on that and respond?
I mean, it is somewhat presumptuous of people sitting at the center to presume that the elected governments of the states are in some way incapable of taking wise decisions. We have to, in a sense, trust their wisdom. It is not that it's nobody's case that you will give complete freedom, or you will. But you are there in each one of the decision-making processes. So, for instance, one of the things which we have agreed today on the restructuring of the CSS, that the decision henceforth as to what elements of those programs will be taken by the state chief secretary, sitting there in state capitals closer to the people, rather than let's say in the case of health mission at the level of the state health secretary, central union health secretary, who's 25, 30,
Sure.
just, the bandwidth, the capacity to analyze the differences of the state's individual problems.
Fair point.
That is the point which I am trying to make. The other thing which we, in a sense, we are not, we are not saying that we will not support the same. Look at how the fiscal space evolves. We will still, transfer more resources as and when, and this is not the last finance commission, there is a finance commission 5 years later.
That's right.
After that. We can keep on correcting these formulations as and when, as in how the things formulate. But to start with a presumption that those people sitting closer to the ground are incapable of taking wise decisions is something.
Yeah, I'm coming back to you. I'm coming back to you. Yes,
This has
yes.
to be corrected. It's
let
not
me-
presumptuous.
You have the microphone, ma'am. Go right
Yeah,
ahead.
it's not presumptuous. It is a question is the center, I'm just trying to make a point, that the center has equal responsibility and accountability. That's what I'm saying. Not that center has, you were in the state, you could go back as a health secretary, so you're the same. So I think.
I'll just
Yeah,
make
yes,
two
Mr.
comments.
Jalani,
I mean,
come. Yeah.
this has been largely the case that India said public health state subject. And you had, I mean, for years, you had, I mean, by the 2004-5, we had 0.9% of GDP being spent on health. And even the later increases have largely happened on account of increase on central government support for this. The second thing, I mean, and I think there is a lot of misgiving across. I mean, I heard a lot of speakers as if National Health Mission, Government of India is telling what the states have to do. If you look at the basic process in the way it goes about, is that there are more than 1,600 odd things from which, and there are all possible additionality which the state want to do. And if you look at a PIP which comes from Kerala and the one which comes from Bihar, there's a whole lot of difference. Kerala is talking of NCDs, UHCs and all.
Sure.
Bihar is talking of RMNCH plus A challenges. The PIPs are prepared by the states. They are the one who decide what has to go in. There is nothing that we can decide. I mean, if I had my way, 3 years back, I would have liked to roll out free drugs because we saw clearly evidence. In 3 years, we've been able to get now 30 states on board, showing them examples, taking them to show the best practices across the country.
Okay.
And having the best practices workshop, and more states are coming forward on realizing the good practices across the country. So NHM, what we try to do is, they come out with all lot of things that this is what they wish to do.
Yeah.
As long as it is within the overall framework, there's no problem. We share them with them, what are the best practices across various states being tried out, based on which some of them they won't want to pick up. But we do not provide any prescription from here that this is what you have to do.
I don't want to make this a battle between you and Mr. Kumar at the Niti Aayog, sir. But since we're talking about redesigning policy for the future, you've heard what Mr. Kumar has had to say. You've heard what Sujata Rao has had to say. Now, from a central government's perspective, what is it that you would like to see being done going forward? How do we address the misgivings that both sides have?
I have no issues. I mean, states ultimately have to own it up. They have to have the capacity. We are there to support. And as Madam said, I mean, Government of India can't wish its hands away. We just need to facilitate, steer, provide stewardship and all. And I think this new arrangement of 60-40, etc., are all fine. My only suggestion, which I noticed, one of the things which the chief ministers have recommended, and I'm aware why it comes from people who would be, say, from finance and planning, etc., is they have said Government of India can continue NHM and 60-40, etc., etc., but HR, no HR. HR, it's only the state government which will fund this. I can easily see, I mean, I can understand the state's concern that over a period of time, it is the states which will have to overall take the responsibility of the HR. But the danger is that for a sector like health, if you want to create more infrastructure, create more buildings without having people, the feet to run it, you will just not have it going. The fact is, we had just 2.5 lakh odd HR in the country. The NHM added another 2,30,000. I mean, if you look NHS, they have 16 lakh people on the NHS payrolls. Together, we have 5 lakh people for a country of 125 crores. So, I mean, it is the
capacity building. Yeah, absolutely. Capacity building.
I think some of the things are dangerous in the kind of recommendations that have come
Some of the things are dangerous in the kind of recommendations that you're making. But I'll come to that in just a second. I know Mr. Kumar will, the smile on your face says that we're being presumptuous again, but I'll come back to you in just a second. But Mr. Banerjee, you've heard the conversation so far now, and I think you can use that microphone. At this point in time, if I were to ask you in terms of short-term, medium-term, and then the long-term objectives that we have, what are the critical reforms or priorities, if I could put it at that, both at the central government's level as well as the state government's level that we ought to be looking at?
Let me start by confessing I have not thought hard about this question. I don't have much to say. Let me say something that may be relevant. I think this entire conversation and most other conversations in Delhi about healthcare happen in kind of a fantasy world where the public health system dominates the lives of people. It doesn't. There's a survey of primary healthcare usage from the country just came out. It's 80% of first visits are to a private healthcare.
Yeah.
Out of those 80%, 75% of those providers have no qualifications to practice medicine. So that the central fact about the medical system is that it lives outside this fantasy world of pushing money between units here and there and everywhere. I think at some level the first step in the process of reform is to take a realistic view of what we can deliver, what we presume to deliver, and where I think where we could have real leverage points. And let me end on that point, which is that I think in some sense the public health thinking needs to be broader than the delivery of healthcare. And I think that point was made by Sujata Rao on immunization. Many of the North Indian states, I actually, having done some of the work on the ground, I don't believe their stated immunization rates. And the full immunization rates are often dreadful. We did a survey in Rajasthan some time ago but the measured full immunization rate was three times what we could find. So I tend to think that if you look at iron fortification, we have gone back and forth. It's one of the places we have one of the world's highest anemia rates. We don't do much about it. Our NCDs are frightening, and we aren't doing very much about it. I think if we take on the question of what the priorities of the health system should be, I think the hiring of doctors by the public sector who then don't show up in the primary health centers is not the priority.
Okay, let me just get you to take that point forward, and then I'll come to you, Vinny, for a comment on that. You spoke about this fantasy world, and I'm glad that you brought this up because, in conference after conference, in conversation after conversation, we do obsess about what the government can do and public health infrastructure and so on and so forth. But the fact of the matter is that, as you pointed out, it is largely the private sector that's delivering on that promise, at least in India today. How do you leverage that? There is a trust deficit that exists. It's a deep trust deficit that exists, and that has sort of been part of the policy intervention that we've seen in the government, and legitimate reason as well for that trust deficit to exist. But how do you leverage the private healthcare infrastructure and the private delivery mechanism?
Let me be clear. I am not a fan of many of the things that the private healthcare infrastructure does. It exists, people use it, but if you look at just the fact that many of these people are not qualified to practice medicine is frightening. That's compounded by the fact that anyone can walk in anywhere and buy any drugs you want. So you have massive overuse of many dangerous drugs. So I think one should be careful, just as a starting point, one should be careful about the word leverage. Because leverage suggests that there is this wonderful thing there, we just have to press on it and it'll go.
Yeah.
It's going much faster than we would like it to go in many directions. And in many ways, I think that the state's role needs to be much more proactively one of thinking of where the regulatory actions are. It's not just a matter of pressing the lever and letting it go. It's in understanding how can we regulate the system. And I think the state has chosen not to regulate it. For one, the access to dangerous drugs anywhere and everywhere is a choice made by the state.
Okay.
You could enforce the laws. There are scheduled X drugs and Y drugs. We don't enforce it.
Okay.
And that the fact we don't do it has consequences for the lives of people, enormous consequences. In West Bengal right now, women who are underweight, want to get married, are taking steroids because steroids make them swell up. And as a result, that's supposed to be, and that has long-term enormous consequences for their lives, but they're doing it. The fact that this is kind of and this is not a medical need.
It's the peril of the marriage market in India. But that's the topic of a whole other discussion, which we can get into. But Vinny, let me ask you this, and I just want to continue with the conversation that we were having just now with Abhijit Banerjee. And again, the private sector intervention and the usual sort of recommendations to the government is that the government should focus on primary healthcare and tertiary should be farmed out to the private sector. Decentralize, give us your infrastructure. We'll sort of take over as far as the last mile delivery is concerned. And again, what is the sort of way forward to judiciously be able to move from where we are currently today?
I think, in fact, one of the biggest challenge of the Indian healthcare system is your private sector, because it is actually poorly regulated, and I'm not sure if the government has the capacity or the motivation to regulate it. How do you solve it? I don't know, as an outsider, or you as an insider. So if you are talking about other countries' experience of how do you get the private sector to do social good? That's the fundamental questions, right? One is through regulation, but I'm suspicious that it will be effective in the case of India. And the other way to do it is through some kind of incentive and purchasing. And the fact that all of the private money right now that is spent on healthcare, the majority is through out of pocket, means that there's no leverage. You use the word leverage. Each individual patient, each individual household, they have no information to try to leverage. Now, I want to separate that between, let's say, a very simple health product where you can, as the government, provide information and education for the patient to say, well, steroid is bad, don't demand it. But once you get beyond that very basic level, healthcare is just complex. And the asymmetry of information between provider and the patient is just huge. And it's beyond just getting your patient to be more to be more intelligent. So somehow in the world's experience is therefore trying to use some financial leverage to change provider behavior. And I think this then connects to the earlier session on purchasing and provider payment change. But this question then backs the other question of, you can't do it until you get the current out-of-pocket spending pulled into some form of pooling mechanism. And what are the feasible ways to do it? I think it's very hard to tell people and say, I am going to mandate some form of insurance, just pay a premium. It doesn't work in the world, and I don't think it will work in India. Most of the other countries where it works is the government still need to put up some taxation money, not 100%, at least as a bait to incentivize you to say, look, pay a premium, but I'm going to subsidize you. You can vary it by population, by whatever. Somehow, the government still need to come up with something. So I'm not sure I would accept the starting point that you gave us, which is the government is not going to spend more money. I would like to open this question. Is there an opportunity to say, can the government spend a little bit more on conditions that the health sector would deliver the following thing? So it's not so much about just spending, but
outcomes.
Are you getting more than what you're getting in the system? And that's the leverage that I see as the possibility. And everywhere countries go through reform, we talk about efficiency, we try to cut fat here, cut fat there. Politically, it doesn't work, right? Providers are now so happy. The private providers are having such a springtime, basically charging prices as they want and then doing things as they like. And so most other countries that are able to try to leverage provider change is also at the time when they're spending a little bit more. It's almost like, I'm going to spend a bit more, you might be earning more, but in exchange, I also want you to change your behavior. So I would like to not accept the starting point that definitely the government would not spend more, but change the conversation.
I didn't say definitely they won't spend more. I said that the government at this point in time says we're fiscally constrained and we may not be able to spend more.
Right, but that's what I'm saying is sometimes we can change that, the context of that conversation. And I think that if that context of that conversation is always about NHM, it's stuck.
Yeah. Mr. Jalani, you want to comment on that? And I know the money is not in your control and that you have to go to the finance ministry for, but you want to come in on...
I entirely agree with her. I entirely agree with her.
Okay, that's it.
All right, that settles the point there. But Sujata Rao, let's talk about innovative ideas and innovative solutions, and then I'll come to you, Mr. Kumar, in just a second. And there's been a lot of talk around pooling and the possibility of being able to do that and so on and so forth. Given your experience in government, and specifically in this sector, how hopeful should we really be of innovative financing solutions?
I think maneuverability is very limited in terms of, I don't know how you define innovative financing mechanisms, but I do believe that taxation will have to be a very important component of whatever type of financing we may think of. And so I don't think Government of India can say 1% GDP and that's it. They just have to spend more. That's the bottom line. The second would be that I do think there is, I mean, this is really after quite a bit of reflecting on this whole issue, that maybe somewhere we need to think about everyone having to take some part of the risk. Right now, the whole risk is being borne by the government. But I think whether it's through copay or whether it is through user fees, whatever that may be, or through insurance, to say that, you know, you protect the poorest for sure, but I don't see why everyone should be given free services. So there is a need for everyone, the citizens and the government, and to also share a part of the risk. But I do think there's a scope in sin taxes, which you know, is not being thought of.
Well, if the GST comes into effect, then the demerit rate is as high as 40% on things like tobacco.
That is true. But I don't know about some kind of innovative financing. Would be bonds. I don't know if we can have health bonds that we can circulate. But the base has to be that we need to deepen and widen the tax base. I can't think of any other alternative at the current moment.
Well, deepening the tax base is something that we've been attempting to do for a long time, and we haven't been successful at all, I have to say. But Mr. Kumar, you know, just to take that point forward, what has been the discussion that you've had at the Niti Aayog in order to be able to address some of the concerns that have been raised by both Vinny as well as Ms. Rao?
Yeah, so the first thing which, you know, Vinny is an expert at China, and what Abhijit says makes a lot of sense to me, looking at what the ground conditions are. But look at what China was able to do between 1950 and, say, mid-70s. They had infant mortality rates better than what we are now. And it is not that at that time, it was not about resources. It is about the choice of where we direct those resources. I think we have, in India, been following more on the curative side and less on the preventive side. And that is one of the reasons for probably not being able to achieve, in large parts, and a large part of why people go to these unregistered medical practitioners is because our public health system deliveries somehow are short, the doctors are absent, the nurses are not there, medicine is not available. And the other part is also because the infectious disease burden we carry is still a very, very substantial amount of burden, which most of the countries of comparable development have already eliminated or are at a very, very marginal level. And that, I think, is one of the failing. I think we have started programs on the non-medical side, so sanitation side, drinking water side. If we are able to do more of that, some part of the problem is addressed. But as regards the non-communicable side, where we see a rising burden and a rising trend, I think the state governments are responding. We have every state government coming out with these covering secondary and tertiary care. Andhra has done it, Tamil Nadu has done it, Rajasthan has recently launched it. Everybody is doing it. There are problems. Some people have done it well, some people have not done it well. But I think not doing anything at this point in time about that particular issue is not an option, because states will willy-nilly go because they have to respond to a felt need of the people, and they are closer to the people. So the point which we need is some kind of pooling mechanism has to be done. How we do it, the sequence in which we can do it, I think that is something which I don't think in this forum it is right to debate. But I think some kind of a mechanism, if we look at a 10-15 year strategy, that will form a part of that strategy. You cannot but deny that.
You know, and it's interesting that you brought this up, because again, in that same conversation that I was having with the Minister of State for Finance, and you know, the need to actually provide a bridge between the health ministry and the finance ministry to be able to even have this conversation there. You know, we've had working groups within the health ministry, working groups within the finance ministry, but no one seems to have been able to bridge the two together.
I think Niti will do it now.
We're hoping that the Niti will do it, sir, but so far the Niti, I'm afraid, hasn't really sort of done much in order for us to see whether the reason why you exist has sort of...
yeah, actually, you see, it's not very clear.
I'm not being politically correct here, but I'm afraid in the last 18 months, we haven't really seen evidence of that just yet.
I think, you know, so Niti was set up on 1st January 2014. The announcement came on 15th August, but the Niti, as it came into existence on 1st January 2015. We are about 8 months old. There was some restructuring issues which were going on. In the meanwhile, we had this whole idea of cooperative federalism, of getting the states. Most of those things are now out of the way. As the year ends, probably we will be able to do it. We are out of the old planning commission hat of allocating resources. Okay, so this money will go here, this money will go there. That is out. So I think we are now, in a sense, we are trying to now. So we are left with two main roles, or rather 3 main roles. One role is the roles of playing the advocate's role for the states, and to bridge this center-state divide. That is the one role. The second role is to look at a more integrative approach, which combines, not really looks at problems in silos of health or finance or sanitation or water, but to do some cross-cutting things and get out some things. And the third thing then is to look at what kind of innovative mechanisms we can do for funding those initiatives. So I think we should really be, in a sense, looking forward to this kind of, and in health particularly, I can tell you that 2016-17, we should see some developments.
We should see some developments. Okay. Yes, Mr.
Shirin, I also think that some amount of restructuring of public spending that's being done by not only Ministry of Health, but Labor, Defense, and everyone, by having one pool, will itself give a huge velocity of a kind. I mean, if you can imagine CGHS, ESIS, the government budgets, everything being pooled, that would come to say something like 20,000 crores. And that pool can really then be the incentive structure to raise the rest of the money for a social health insurance of a kind, where you can really cover about
What is the problem there? Why do you believe we haven't been able to do it?
We haven't been able to do it. This did come up for detailed discussions in 2005. It is basically because politically they were not able to negotiate with our government employees who didn't want to give up the CGHS benefits, which is a blank check. I mean, I as a CGHS beneficiary, unlimited amount of care I can consume, and I can even go abroad for treatment if required. So, that sort of the benefits that we've given our employees, or the ESIS is another area. So there has to be, that will also give the government the leverage to set prices. If not through regulation, by being a very significant buyer of private services is one way we can discipline the private sector. But I do see that in the future, much as ideologically I would love government to be the main provider and purchaser and so on, but I think the mistakes that we have made in the last 70 years, it'll have to be a public-private partnership, which we have to engage with the private sector for expanding access.
Okay.
And I think this kind of new instruments of financing will be required.
Good points. Vinny, sorry. Yes, Mr. Dulani, you had a point to make, and then I'll go to Vinny. Since you have the microphone, I assume that you have a point to make.
Just for us.
No, let me say that, while I think there is very good evidence and states are going in for Arogyasri and all that, at the same time, I think there has to be a very, very clear understanding that where we need to prioritize whatever money that we are spending from the government. I think really comprehensive primary care. We spend some money on the RMCH side. Now, Abhijit mentioned about the NSSO, this thing, which 80% is private sector. Only thing that you notice is that we spend money on RCH was a major focus. Very limited selective primary care we provided. It was limited to RMCH, then some communicable diseases, etc. Right. Nothing else was there in whatever limited support we provided, training, etc. we provided. But there you could see that from 20%, it went up to 53% of all childbirths in public facilities. The cost of childbirth in public sector is 1/10 of that of private sector. It came down where we spend money, and the lower quintiles could make use of it. So now the reason, the market forces have failed. So basically people are, the private sector is not prepared to go to the rural areas.
Yeah.
Government has not funded, and then we have not really set up good systems to monitor and ensure that we get value for money. So there are huge gaps of inefficiencies, etc., etc. But my own sense is we need to put in more money. We need to put in money on the primary health care, comprehensive primary care, universal primary care, which is not happening, and states need to prioritize that and then build on that and then provide for our insurance coverage. Otherwise, no way we can support these kind of curative services without taking care of our primary care.
Okay. Winnie, you want to come in on that? And also just to pick up on the point that Mr. Kumar was making about the China experience as well, if you could.
Before I do that, I actually want to respond to what Sujata said. I think, again, the global experience is when you have multiple scheme or multiple beneficiary groups, trying to put them in one risk pool is impossible because, again, it's self-interest. But what India can consider is, going back to what we started talking, is a floor. If you can decide on what is the floor that everybody is entitled to, you can still get the civil servant and all these other schemes to contribute that part into this floor scheme. Then this floor scheme would be very powerful to leverage changes in the delivery system. Then the rest of it, the civil servant, whoever, you still enjoy your benefit as it was. It's just that the amount of money that the equivalent of the amount of money that is needed to fund the equivalent of that floor benefit package, that bit needs to be poured with everybody. So I think it could be, we can be creative about that. And yes, you're still having a two-tier system with inequity, but no country in the world is, I mean, like you enumerated 6 or 7 objectives that India wants to achieve. And I mean, if a country is honest, you should say, at this stage, what is my priority of these objectives? And when I have more money, I would move to the next bit, rather than saying, I'm not going to spend more, I'm not going to raise more money, but I also want to achieve 7 objectives.
There are actually more than that. I just articulated the 7 main points, but I think there's many more. But Abhijit Banerjee, you want to comment on the conversation so far, and then I'll throw it open to the audience.
Just a couple of points. One, I think, is, I mean, there are, in some ways, I'm speaking at cross purpose with this conversation, but I feel that a few things are kind of useful to add. One is, I think that this enormous force of people who practice healthcare, they're not about to go away. Given that, the fact that we don't acknowledge them means we don't do anything about it. I think in some ways we want to, I think it's fundamental, we need to start by acknowledging that this is the basis of most of primary care. And if we did, then I think we would be able to, A, offer them some training, and maybe then slowly bring them inside the regulatory nexus.
Okay.
Because I think that's I think it's key to acknowledge that. The second point, which is perhaps where I'm, my experience suggests that maybe we need to be more radical, is I think in terms of thinking of where, given that, this battle about resources will go on for a while, I think my sense is that you deciding that we're going to spend money on a few things but spend it well would, partly we do, in everything, we do too many things and we don't do them well. And deciding that we're going to do, my sense is that a few things like the classic public health objectives of, water, of immunization, of I'm a big believer in fortification, so, get those things which are relatively straightforward to do. The financing needs are very limited. But I think the reason why they don't happen is because they get lost in the morass of many, many things that the government needs to do. So, I mean, we can make a list of what the 10 things the government should do would be, but it seems to me that that would be a useful place to start, rather than the idea that, again, the fantasy that we're going to do everything and then not do it.
Okay. You want to make a quick point? No, she agrees, actually.
No, I don't agree with you.
Oh, you don't agree? Okay,
No.
sorry.
India has paid a very heavy price with the selective primary care. That was the worst decision that India took, all on this argument that we don't have enough money. So the point is that time has come when we just have to come and define for ourselves what is the basic minimum that every citizen must be entitled to get and must be provided that, Otherwise, just do cherry picking some little bit of malaria, a bit of TB. But poor people are not suffering just because of TB or malaria or immunization. They have backaches, they have headaches, they get fevers, and where do they go? And that's why the quacks are prospering. So I think there has to be very solid primary care, comprehensive primary care in the classical alma mater sense, which has to be provided, and in this case, I would say free of cost to everyone, rich and poor alike. And that should be the fundamental objective of the government. So I don't agree that we don't have money. We have enough money. Andhra government wants to spend 1 lakh crores on building a capital. Now, if you can get that kind of money, and they spend 400 crores in giving saris, dhoti, and rice to every citizen. If you have that kind of splurge, money to splurge, you jolly well can also give this to every citizen. So I think there's a huge amount of reprioritization that needs to be done, number one. And number two, since we're closing, I think in this whole devolution debate, more for you, Anne, is that, the states just don't have capacity. Really, they have very, very poor capacity, technical capacity to sit and analyze data and to analyze a lot of work that needs to be done. I'm not therefore saying that the center knows everything, state doesn't know, but the point is there is... No, it's really a very serious... no, they will agree with me, and I know Aarti agrees with me fully. This is really a problem, and we need to work on this.
I've got lots of hands, so quick point from you, and then I'll get the questions.
I guess my disagreement, I think, is fundamental. In a sense, I have maybe such a low view of how our capacity to make our health systems work has been, we are at the point where many of the doctors don't show up for work ever. Given that, I think pumping more money into that system before we fix the incentive seems to be a deep mistake.
And I think there was disagreement over this issue in the previous panel as well. So I'll bring in questions.
This is a very interesting discussion. I would like to make few comments on what Niti said and Madam Sujata Rao said. I will give the perspective from the state because I'm the finance secretary in one of the state.
Yes.
And there from last 4 or 5 years. One is that what Finance Commission has done is to give more devolution to the states. And as we had a previous speaker here, he gave an example of Finland, that for 5.5 million, they have a devolution, and they think that the country level cannot decide, it has to be the local level. So we have the states bigger than the Europe, countries in Europe.
Right.
So obviously the states have to be, trusted,
Sure.
more responsible, and money has to go to them.
Sure.
So obviously that is the right direction which has taken place. Regarding the second point Madam Sujata Rao mentioned, is that there has to be uniform standards. Every citizen should get minimum services. I have gone through all the Finance Commission report, till 14th Finance Commission report. The money devolution has been to the poor states. If you see the per capita devolution, it has been much more to the poor state based on population and poverty than to the better states. So it is not the money alone which leads to outcomes. What Mr. Abhijit said is that governance issues and delivery issues are very important.
Right.
We cannot say that by pumping money alone, we will get the delivery.
Fair enough.
There has to, I would just complete on another issue. The issue about financing, because the main issue is the financing. Health sector need more financing, but I see two issues at the national level and the state level.
Right.
The national level today, we have a fiscal constraint.
Yes.
But if oil rates, if goes up, then we will have a major issue.
Yes.
At the state level, we are in a better position today. But the seventh
Pay
Pay Commission report, I don't know what will be the situation.
Absolutely, it'll burden both the center as well as the state.
So I will just complete in 2 lines. The overall kitty is going to squeeze. Now within the kitty, if we want more funds for the health sector, what Mr. Govinda Rao said was that we have to prioritize within the centrally sponsored scheme. That overall devolution from the central government was 65%.
Yeah.
48% is gone from 14th Finance Commission. We have a kitty of 17%.
Right.
You spread to many CSS or you give to health. We have to decide.
Mr. Rao is right behind you, sir. So if you can give him the microphone and he can maybe respond to your points as well.
Thank you. In fact, this is an issue which was discussed in the morning. If the Finance Commission has increased the tax devolution, now it has left certain amount of fiscal space for the union government to undertake, the specific purpose transfers for ensuring minimum standards of public services. Yeah. You see, Finance Commission only enables the state to provide comparable levels of public services. It doesn't fully offset the revenue disabilities even though it says it's a pro-poor, per capita income in Bihar is 1/5 of per capita income in Haryana. So that means that they should get per capita, in terms of per capita, 5 times that of, Haryana. Anyway, that apart. If you have that, and in the union budget you made 50, sort of you cut down on some and continue with 50 centrally sponsored schemes. And the Chief Minister's Committee comes and says that everything is core. In fact, all these things are considered core. If you really think that health is an important area, you would have, in fact, the Finance Commission made a recommendation that have only 5 centrally sponsored schemes in areas like water supply, sanitation, and, sort of public health, elementary education and the like. Instead of that, if you want to spread the resources thinly across this thing, then you obviously will not get more money for the health sector. So I think, I don't know who serviced the CM's committee, but the basic point is that I think we are trying to spread our resources, whatever little resources they have, very thinly. And I think that's the thing that we need to. On one issue that you mentioned, on the demerit tax rate, the 40%, actually today we have a higher than that.
That's right.
Okay, I mean, in fact, some of the state governments itself themselves are charging 40% on cigarettes. In fact, there is something wrong with the way they have calculated the demerit rate. I think it should be possibly 80%.
Well, industries made a representation just this morning saying that it shouldn't be anything higher than 25%. But yes, sir, if, Mr. Rao, could you please pass on the microphone, sir? Thank you very much.
Thank you. I wanted to make 3 very quick comments. This is going to take 1 minute. The first one is that I am surprised that we had 4 gentlemen this morning and in the afternoon who made fantastic presentations about other countries that have undertaken health system reforms that have been very successful in OECD countries. Those countries came up with answers to the majority of the questions that you're raising and the majority of the problems that we are facing in the debate today. But what surprises me is that nobody ever here has made any reference to the kinds of solutions that these other countries came up with, which were quite successful. So I wonder, why is it that in this debate about solutions to the healthcare problem of India, these very valuable lessons are not being considered at all, as though India was so different from every other country that they're irrelevant. The second thing is that 2 people have talked about public health goods, Abhijit and Jeff Hammer. I think that if one compared how much India is spending per capita on public health interventions, such as sewerage, sanitation, potable water, public health education, the difference between India and the other countries would be even more dramatic.
That's right.
So there is a huge gap in public financing, because it has to be public, for those interventions, and that would have a tremendous positive impact on the disease profile in the population, and I wonder why that is not an issue that's been discussed. And the third one, and finally, is that this floor that Winnie was talking about, or that Abhijit was talking about, what are those services that should constitute the minimum acceptable for the entire population? Is there a consensus about that, and shouldn't that be a starting point?
Okay. Sujata, you want to start with that, and then I'll take the other points that you made.
I think the reason why Turkey and, say, Thailand, for example, are not being taken up because there's a 75% is public provisioning, and Thailand spends 17% of government revenue. So the whole debate, the crisis in India is that we are not spending enough. As per GDP, it's 1%. States, out of the government expenditure, it's only 4%. So time has come when we really need to look at the structure of public financing in our country, because out of, say, $100, a state like, say, most of the states spend 75% are committed liabilities. Only $25 is left, 25%, for all development expenditure. So our tax to GDP ratio is low, our government to GDP ratio spending is low, and so with these kind of indicators, amount of money on health is affected, and unless and until we invest more, we cannot match up with Turkey and Thailand, because basically public provisioning is far, far cheaper than private. There's no doubt about it. But then this is the problem. And as for your second question, that's exactly what I meant by basic package. If we could only attend to basic health care, that's basic preventive primary care, immunization, everything goes into it, and sanitation, nutrition, and water supply, we'd bring down morbidity by 50%. Today, a major number of children under 5 are dying of diarrhea, and that cannot only be resolved by a rotavirus, as long as they're drinking contaminated water and defecating out in the public. So we just have to invest, and when you really, as you rightly said, when state secretaries say we have enough money, they're benchmarking themselves at a very low aspiration level of doing those 2-3 things that Manoj wants them to do. So money is enough. But if you really look at the fact that, as everyone got tap water, everyone has a toilet, everyone is nutritionally healthy, everyone gets access to basic primary care, deficit is huge.
Any more questions here? Yes, sir.
There was just one comment, basically, that, when Alok talked about, and I think somebody else also talked about these health financing, innovative health financing schemes and all, which the states are doing, I think the biggest challenge what I see there is that they are basically looking at secondary and tertiary care in most of these things. And all the innovation which the government is thinking is coming in that through demand-side financing and all. But on the primary care, whatever NHM is doing is the only thing. But the states have not done a lot of new innovative financing mechanism. Like, for example, capitation is done in Thailand, and which was quite good. But so I think the need of the hour also for the states is to look beyond these very populistic tertiary care 2 lakh package, 1 lakh package, which are very catchy, but also to link them with the primary care health financing innovation at the state level, which is something which is lacking, I feel.
Vinny, you want to come in on the point that that the gentleman just made there?
Not everything, but he's alluding to a question, an issue which I think is important, because I think in India the conversation tends to be a bit fragmented in the sense tertiary care, this money deal with that. Secondary care is unclear where it falls into. Primary care is another entity. And I just want to bring to the discussion a little bit more of a forward view is, the Indian population, yes, has infectious disease incidence, but NCD incidence is growing really fast. And what is the world's experience of the most cost-effective delivery system is an integrated one. And if the conversation continue with these tertiary, primary, public is primary, tertiary is private, I think you're going to be stuck in a long way that there's no return. I think that needs to be brought into that conversation a little bit. And I think what Thailand initially trying to do is to give the community level a capitation budget that integrate all the way from community outpatient to inpatient. It's a good way forward, but they also have learned the lesson that politically it is complicated. But you don't have to do it in a comprehensive way. You can identify a few priority non-communicable diseases and see if you can pay your team of provider. I think you need to begin to say, how do you get your provider to coordinate rather than we each do our own thing and build up more silos?
I have a couple of questions actually. Since morning, we have been listening about 3 things actually. One is the pay for performance, second is the accountability, and third is the state, health is a state subject. I have actually comment and questions for all 3 of these things. First, let's come to the accountability. Accountability is actually a very sensitive issue because currently in many states, we don't have transparency. And without transparency, I don't think we can actually create accountability among the frontline workers or, let's say, service delivery points as well. Now, that's one question, that how do we focus more on transparency? Because if we look at monitoring, which cannot be done on a real-time basis, So until we create a transparency through which even the state headquarters can do the monitoring.
Okay.
I think that will help the accountability even more. That's one. Second question will be related to pay for performance. Pay for performance, we have been discussing a lot. But I think pay for performance actually leads to supplier-induced demand. Now, this is the reason why many interventions in certain states are working in competition rather than collaboration. Now, my question is basically, is this competition favorable for the general public?
Okay.
If not, then what should we do to make it collaborative effort? That's another. And third
Okay.
question, last question I
Yes.
have is basically, that's a small one actually. Health is not just a state subject, health is a cross-cutting subject as well. So how do we work towards moving towards integrated model? I mean, we need
Yeah.
to have interdepartmental integration
That's right.
to
The point that Vinny
Yeah.
just made. Thank you very much, Mr. Rao. Do you want to address the second question that the gentleman raised on the pay for performance? Yeah.
Yeah, you know, as long as you're going to be giving, topping up on a procedure-based pay for performance, you're going to find this kind of perverse behavior. But if you were to say that, like what UK does, a patient comes in with an X amount of diabetes, over 6 months of treatment, it's recorded that his levels have come down or hypertension is controlled or whatever, that's an outcome. And then they get scores and they get a higher remuneration. And that's being tried out in social enterprises like Nationwide, in Bangalore, Health Spring in Bombay, in their primary care clinics. So as long as we can have outcome-based performance, that means we are incentivizing him to see that he takes care of the patient and gets the correct outcome that we want, then he gets paid. And not that number of hysterectomies you do, you will get paid per hysterectomy basis. So he just does hysterectomy on everyone. So that's what we are doing, which is wrong.
Okay. Mr. Kumar, let me start by asking you for wrap-up comments, because you said that 2016 is when we can expect big things as far as the healthcare sector and healthcare reforms are concerned. Give us a snapshot, really, of what we're talking about here.
Yeah, well, in a sense, number one, what I wanted to say was that, you know, one thing which we have been lacking so far and which has resulted in our poor health outcomes has been the ability to invest on the prevention side. It is a one-time solution. If we can get it, then we'll be over with it. And that needs to be focused, and therefore, I mean, and that is not non-health solution in a sense that it lies outside in drinking water, in sanitation, in hygiene, in education, in so many other things. And that, I think we need to get our act together with that. The second part is that what I wanted to say was that states, because they have the arms and the legs, because they are our implementing agencies, so because all the doctors, all the nurses, all the paramedics, etc., at least insofar as the public health system, report to them. So we have to take them into confidence in partnership, only then we can go forward. So that is there. The third point which I wanted to make was that if only 30% of your space is about what the public sector is delivering, the 70% of the space is open. The government will have to find some idea of some way of engaging with this 70%, because you know, the regulation part in a supply constraint situation where you, as it is, don't have a number of doctors or paramedics, even if you put some of them out of practice, what are you doing? You are not really achieving. So regulation at this point in time may not be the real answer. The real answer will then be, therefore, how do we engage with this private sector? And I think we need to take the bull by the horns. I understand there are trust deficits, I understand there are problems, but at one point in time, we need to attempt this, and this is exactly what we'll try to attempt.
Okay, that's what you're going to try to attempt. Mr. Jalani, what are going to be your priorities in the new year, sir? Yeah, this is the New Year resolution. We'll check back with you at the end of 2016 to see if you've actually been able to achieve them or not.
Well, I would first say I agree with what Madam Sujata Rao and Alok said. The only thing is that, yes, I mean, few things that one is saying is that, one, as I said, we have to think in terms of comprehensive primary care, and you know, this idea about getting on a basis of capitation and then outcome-based payments, etc., and trying to design our payment mechanisms in a manner to get the better value for whatever we have been investing, and this additionality that we try to put in the system. We need to put in more money, there is no doubt about it, but that money should be able to not only, I mean, should be able to enhance the value of whatever we are putting in by way of public funding. There is a need, and of course it has to be riding on an IT platform which to facilitate the continuum of care, because you will have a case of, I mean, you have to have a clear referral systems and then a follow-up, etc., etc. So as Vinny rightly pointed out, it has to be an integrated and continuum of care. So that needs to be strengthened through an IT backbone. The other thing that's happening, I mean, which again would be integrated is in terms of some kind of, even this model about providing to take care of catastrophic healthcare spending in terms of curative services, is that there is going to be, I mean, the proposal is to have basically a platform where Government of India comes and provides that these are the kind of services that would be catered to, and this is the kind of premium that support that we would be providing to the states for all the poor, and then various mechanisms would be possible for the states to adopt trust model, insurance model, to expand it horizontally, to expand it vertically, to allow for voluntary joining, etc., with some degree of facilitation. That's a broad direction.
So this will
Thanks.
happen in 2016?
I mean, we are moving in that direction. Let's hope it materializes. Thanks.
Okay, Vinny.
I just want to make one comment. I feel that a lot of the issues that we raise about transparency, accountability, and also the sort of debate that we have had for the whole day would be much more improved if we actually have evidence and data in front of us. I feel a lot of the discussion is still very muddled by opinion, by impressions, so it just doesn't move forward. And it surprises me because India is such a country with so many IT capacity. So what is the data collected used for?
No, you're absolutely right. I think that, I mean, we're seeing that. We've had a Supreme Court order today, which again, I don't think has really taken into account hard data, so on whether diesel vehicles should be banned in the National Capital Region or not. But yeah, data aside, Abhijit Banerjee, closing comments from you.
Well, actually, we have data. I don't think that's quite right. I think we have lots of data, just nobody likes the data. It is unpleasant. No, actually, we even analyze it, we put it out there. There's been work on governance failures in health for the last, and evidence. I think we're both evidence and data, and we've been doing it for a while. I'll tell you one story. We tried to get the government of Rajasthan to agree to have the nurses come to work just 50% of the time. If they didn't, then they would have to be, after many warnings, will be given some fine or something. That created such a fuss that the nurses basically got their bosses to say that, well, now on, every day I don't show up will be marked as an exempt day rather than as an absent day. And as a result, the total number of days they were not there went up as a result of this intervention and not down. So, this was a randomized control trial. It was so it was literally, the effect was went in exactly the opposite direction. I think the will to put in serious incentives is not there. And it's not there in droves. So it's not, I will, in that sense, I don't think that it's not that we don't know what the problem is. I think everybody knows kind of what the problem is. Let me say one last thing, which is that I think one other piece of the conversation we should be having now is sort of the demand side of all this, which is why do people go to these quacks? Well, part of the reason is that they're available, they're convenient, but part of the reason is that we regulate the public system so that they can't get shots, and they'll tell us this doctor is not good because he doesn't give us shots. And so I think starting all the way from there to all the NCDs, I mean the level at which people understand healthcare. And so I think we brush this under the rubric of education, but it's something much more specific and targeted than that, and we need to work on that.
All right. Well, there's plenty that we need to work on. The government promising us that, yes, they will certainly take this forward in 2016. The Niti Aayog promising us that they will play facilitator between the Ministry of Health, the state governments, as well as the Ministry of Finance. And stakeholders here feeling a little more hopeful about the road ahead, but a lot will depend on implementation and execution. A lot will also depend on political will and actually having the courage to take some of the tough decisions that are required at this point in time. The good news is that there seems to be consistency, as the gentleman pointed out, that at least as far as the last 12 hours that you've been having this discussion in this room, at least everyone is on the same page and aligned to the same objectives. Hopefully, we will take this conversation forward and be able to actually achieve some of the outcomes that have been discussed here today. Thank you very much for joining us here this evening. Appreciate your time. Thank you very much indeed.